Good afternoon. Welcome to our 8th annual UCSF School of Dentistry Global Oral Health Symposium. I'm really looking forward to an engaging afternoon with some very accomplished and talented speakers on a topic about which I am very excited to learn more about. Putting together an event like this takes quite a bit of planning. I'd say it was 9-10 months ago we started thinking about getting the word out, identifying the speakers, finding the venue, finding the right date, and really trying to identify the right theme. Some of that comes from our Global Oral Health Steering Committee and their input and suggestions, and a lot of that comes from our audience as well. My name, by the way, is Ben Chaffee. I'm the director of our program in Global Oral Health at the School of Dentistry. And this year our theme is health and oral health of refugee, migrant, and immigrant populations. This is a topic that is very much in the national consciousness, debate and discourse at all different levels, and certainly how this movement of people and communities across borders and within borders impacts health is something I think we can all learn more about. So many thanks to people who make this event happen and come together. You see their names in the programs. We'll have more formal thanks for them at the end. But a few thanks up front. First of all, to our presenters who came a long way to be here and enlighten us today. Thank you to everyone here for coming out and being part of our audience. Also, a big thanks to the Philip R. Lee Institute for Health Policy Studies. Thanks to their co-sponsorship of this event, we're able to have the symposium filmed, and that'll go up on the web for many people to watch who couldn't be here today. Folks like my mom, who is going to promptly fast forward through all of the content to catch the part where I tell you it's time for break, then fast forward to the end when I tell you it's time for the reception. Hi, Mom. But in addition, for other folks who are really interested in what our speakers have to say, it's a real resource to have that up online, and we're really grateful for it. Also, big thanks. Many of you know our program was founded and really started with the leadership of Dr. John Greenspan. We're really happy that he's here today. He was our inaugural Associate Dean for Global Oral Health in the School of Dentistry, and we wouldn't have had this program today and this program in a larger sense without his leadership. So thank you, John. And also a big thanks to John Featherstone, who, as Dean of our School of Dentistry, really embraced this vision of having a program in global oral health. And it was through John's support and the support of the Dean's office that we're able to offer these opportunities for our students and our faculty to engage in global health. And since John Featherstone has retired, our ship has ably and skillfully and humbly been sailed by Dr. Mark Kirkland, who took on a big job of stepping in as interim dean for the School of Dentistry. Really, really thankful for his continued support of this program. Just want to say publicly, big thank you to Mark Kirkland for stepping in and really doing a great job. It's greatly appreciated, and in fact, thank you too for sharing a few words with us. So enjoy the program, and Mark Kirkland.
We're here for the Global Oral Health Program, the Symposium, and Ben did mention Dr. John Greenspan, who started this many years ago. John's in the back there. John, welcome. John has worn many hats since his time here. He's been department chair. He's been one of our first, I think you were the first Associate Dean for Research as well, and the Associate Dean for Global Oral Health. And Dr. Chaffee stepped in this role in 2014, I believe. Thank you for stepping in. You're doing a fantastic job. We're fortunate to have you. And so in preparation for this, I took a look at a number of things, and I did learn a number of things about the Global Oral Health Program that I wasn't aware of. And one of the things is the program offers 2 different fellowship opportunities. One is in community partnerships, and one is in research. And what I found out is since 2013, 26 dental students and residents have engaged in global oral health projects at partnership sites in 12 different countries. And so that's pretty phenomenal. So congratulations on that, and thank you both for making that a possibility. What we also know is there's a didactic program in global oral health. It's available to all trainees in the school, so that means students, residents, and others. And so you didn't come here to hear me, you know. I just came in to make some welcoming remarks. But what I do want to do is welcome Annie to the stage. Annie, would you come on up? Thank you.
Good afternoon, everyone. My name is Eni Obadan-Uda, and I'm here to introduce the first speaker, Dr. Fatima Karaki. Dr. Karaki is an assistant professor with the Division of Hospital Medicine here at UCSF. She obtained her medical degree from the University of Michigan and completed her internship and residency at the Washington University in St. Louis. She is the founder and director of the Refugee and Asylum Seeker Health Initiative, also called RAHI, at UCSF. RAHI aims to foster academic activity, research, education, and community awareness in refugee health. She is also the founding member of the North American Society of Refugee Healthcare Providers and a member of the UCSF Global Health Sciences Faculty Affiliation Program. Dr. Karaki has provided emergency medical relief to patients in camps and slums throughout Europe, the Middle East, and India. In fact, she is a leader in the refugee awareness movement in the Bay Area. This afternoon, Dr. Karaki will discuss the global refugee crisis with a focus on the unique health needs of refugee and mobile populations. She will provide a broad overview of the most common health issues observed in the Syrian and the Rohingya refugee crisis. Ladies and gentlemen, please join me in welcoming Dr. Fatima Karaki to the podium.
Thank you so much, Annie, for the introduction, and thanks for the opportunity to speak, especially to Dr. Chaffee, Dr. Kirkland, and Dr. Greenspan. So I'm going to talk to you today about refugee health and some of our work here at UCSF. I do want to mention that some of these topics can be a little bit graphic or disturbing for some viewers, so please feel free to step out if you feel the need. And my other disclaimer is that even though this is a symposium on oral health, I am not a dentist, I'm a doctor. And so there's a lot of refugee health in this talk, not so much oral health. I hope you'll still enjoy it. I have no financial disclosures. So today we'll talk about the basics of human migration, some of the health challenges that we face in different health refugee crises around the world. So we're specifically going to talk about the Syrian crisis, the Rohingya crisis, and the Yemeni crisis. And then we'll explore some challenges in providing high-quality refugee health care and talk about my organization, the Refugee and Asylum Seeker Health Initiative, or RAHI for short. So I want to make sure that we start all on the same page with some definitions. A refugee is somebody who is forced to flee their home country due to fear of persecution. And Article 1 of the 1951 United Nations Convention states that that fear of persecution has to be from one of 5 reasons, which are race, religion, nationality, social group, or political opinion. An asylum seeker is somebody who is seeking international protection, often for those same reasons, but their claim has not yet been decided by the host country. And so they have made a legal application for asylum, and when that application is approved, they become an asylee. So every refugee is by definition an asylum seeker, but not every asylum seeker is a refugee. And then an internally displaced person is someone who has been also forced to leave their home, but they have relocated somewhere that is still inside their home country. And so what you see common to all of these different populations is that all of these individuals have been forced to involuntarily leave their homes, as opposed to other groups of mobile populations like economic migrants who may leave their homes by choice to search for a better life or better job opportunities. And you can imagine that if this was your home and that was your apartment, and your car, and your street in Damascus, and now after the Syrian civil war, your street looks like this, that as much as you may love your home and you don't want to leave, that you're forced to leave. And so even though there's a lot of negative rhetoric about large groups of refugees coming into different countries, these people unfortunately leave out of desperation and they really don't have a choice. So right now we're in the midst of a global refugee crisis, and that's a huge topic in global health today. We have 65 million forcibly displaced people worldwide, which is the highest number of people since World War II. That includes almost 22 million refugees and many millions more of stateless and internally displaced people, okay? So when we look at the global refugee crisis and we kind of look at its distribution around the world, what becomes immediately obvious is that the vast majority of that burden is in the Middle East and North Africa, with 70% of refugees in those regions. And half of refugees worldwide come from just 3 countries, which are Syria, Afghanistan, and Somalia. The countries who host the most refugees in the world are the neighboring countries to Syria and Afghanistan, which are Turkey and Lebanon around Syria, and Pakistan and Iran around Afghanistan. So, and I want you to keep Lebanon in mind for just a moment. It's hosting over 1 million refugees. One of the important points in this talk is to debunk a lot of myths around refugees and migrants. So one thing I want to point out is that even though we hear a lot of negative press and media about large numbers of refugees coming to the West, coming to our countries, disrupting our economies, the fact is that 86% of refugees are actually hosted in developing countries. And why should we care? There's a lot of people who have different reasons. I think most of you probably care because you're here today. Some people believe that we don't have control over our circumstances of birth. So just as easily as we're sitting here talking about refugees today, we could be a refugee, or we could be a refugee in the future. Some people believe that as the richest country in the world, that we have sort of a humanitarian obligation, a moral and ethical obligation to support those who are less fortunate. Or others may come from families of displaced people or refugees themselves, or they may have some sort of personal connection. But even if none of those circumstances applies to you, many of us work here at UCSF providing medical and dental care, and we have an obligation as part of our mission at UCSF to provide the highest quality care. These groups of mobile populations face very unique health issues, and we need to understand what they are in order to provide the best care. So this is a pretty busy slide, but here in the United States, we do resettle a number of refugees annually. Resettlement means when a government selects the most vulnerable refugees in the world who cannot return to their home country and also cannot safely stay in their host country. And so those extremely vulnerable refugees, which constitute less than 1% of refugees worldwide, are selected for resettlement, often to the United States. And that process is one of the most rigorous and exhaustive processes in existence. So it takes up to 2 years, during which time the refugee remains in their host country. And it involves 8 government agencies, multiple background checks, multiple medical checks, biometric data. And so every precaution is taken to ensure the safety of both the refugee and the home population. And then once the refugee gets here to the United States, they are supported by refugee resettlement organizations for the first few months after resettlement. The president determines the number of refugees that is resettled per year. So under President Obama, that number was rising year upon year to a maximum of 110,000 in 2017. And then under the current president, that number has fallen sharply. So for 2018, that number is going to be 45,000. That's the lowest number in almost 40 years, since 1980. And you can see that in the graph. California remains one of the top 5 states for resettlement, but even our numbers have dropped. So in 2016, we resettled about 8,000 refugees, and then in 2017, that dropped to 5,000. Most refugees are not resettled in the Bay Area because of high cost of living here, so the top cities for resettlement are Los Angeles, San Diego, and Sacramento. I asked you guys to keep Lebanon in mind, and that's because that's how I got involved in the refugee crisis. This is a picture of my village in Lebanon in the Bekaa Valley, which is just a couple hours from Syria. This is our farm. I saw how the Syrian refugee crisis was affecting Lebanon. There's over 1 million refugees in Lebanon right now, and the country is very tiny, less than 6 million people. So we have the highest number of refugees per capita of any country in the world. And I saw them on our farm. And that's really how I started getting involved. I started as a volunteer. I did boat rescues in Greece. So many refugees who leave Syria travel across Turkey, and then they pay a human trafficker to get to the Greek islands in order to seek asylum in Europe. So I met some people making a documentary about that, and I just wanted to show you a brief portion of that documentary.
بالنسبة للطفل هي كل شيء، يعني تعطيه القوة، تعطيه الصبر، تعطيه كل شيء. يعني كنت دائما أقول لا سمح الله إذا أولادي غرقوا بالبحر أنا إيش راح يكون مصيري؟
سوريا بشار أسد ظالم أطفال كبار صغار طيران روسيا الصين إيرانيا عالم كله على سوريا كله سوريين أطفال كذا هاوس أطفال.
فأنا كنت حاطة قدام عيني كل شيء، الموت، القتل، كل شيء كان حاطة قدام عيني. يعني بالنسبة لي صعبة كتير، كانت يعني حياة صعبة للغاية. يعني مثل أي مرة كنت بحلم ببيت حلو كبير، يعني يكون لي أولاد أدخلهم بالمدارس بالجامعات، يعني أحلام يعني. بس يعني كنا نعرف إنه هالأحلام ما رح تتحقق، آمالنا كلها تحطمت. كان لابد من إني أطلع من سوريا. تهجرت بشكل يعني بشكل لا يوصف، والرحلة كانت صعبة كتير، يعني كان فيها مشقة، تعب، إرهاق.
كثير عم نعاني. هي صار لنا 16 يوم فقط على الطريق، والأطفال ماتت من البرد، النساء تجمدت، يعني شباب ما عم تقدر تتأقلم مع الوضع، فالنساء والأطفال كيف حيكون وضعهم؟
شو اسمه المنيحة انه عطونا اواعي واكل وهي، اللي مو منيحة انه شو اسمه الجيش يضرب علينا ويوقعنا ورحنا نوقع بالوادي.
يعني من سنة هون واللي من 10 أشهر هون، يعني ما بيعرفون إيش راح يكون مصيرهم. من 10 أشهر وأنا ما شفت أولادي. آخر يوم شفت فيه أولادي تغدينا سوا، ودعتهم، وهن كانوا يعني على علم إنه أنا خلاص راح أطلع من سوريا.
Has everyone here heard about the Syrian refugee crisis? Yeah, most people have heard of it. It gets a lot of media attention. Let's spend a couple minutes talking about that crisis. So Syria, before the war, had 22 million people. The war has produced 5 million refugees in addition to 6.5 million internally displaced people. And as I mentioned before, the bulk of those refugees are located in the countries around Syria. So Lebanon with 1 million and Turkey with almost 2 million refugees. But most of the press and media that we hear is about Syrian refugees coming to the West, coming to Europe and America. And that's what you saw in the video. So For a refugee seeking asylum in Europe, typically they will cross with a human trafficker at about 1,000 euros per head over to a Greek island. And then from there, it's a pretty long journey. They have to travel to the Greek mainland and then through Eastern Europe, through about 10 countries in Eastern Europe, Macedonia, Serbia, etc., until they reach Germany in Western Europe, which is where they seek asylum. And that journey is pretty strenuous on the body and on the mind. When we treat these patients, we see an immense amount of physical trauma from the journey and exposure to the elements. People have left under duress. They're not particularly prepared to spend months or years living outdoors. And so in the summer, we see a lot of dehydration and heat stroke. In the winter, we see frostbite and hypothermia. Many children have died of sleeping in the cold outside. People have been often exposed to torture. And then once they reach their destination, it's a significant cultural adjustment, and there is quite a bit of anti-refugee and anti-migrant sentiment in Europe. Many times the media will use the term migrant rather than refugee because that's a more neutral term that invokes less sympathy. So in addition to the sociocultural barriers, different religion, many refugees also experience hate crimes as well. I took this picture of the feet of an Afghan refugee whose shoes were stolen, and he walked through Iran in the snow. So all of his toes have frostbite, and we did take him to the hospital where he was offered amputation. But when he learned that it would take several weeks for his stumps to heal and then to learn how to walk again with physical therapy, he looked at his other 12 family members who were with him, and I know that he was thinking about those 10 countries that he had to pass through and the difficulties faced at each border where they would be processed, and he refused that amputation, which means that those toes will ultimately become gangrenous and rot, and that infection can spread to his blood and he can die from that. We also see a lot of non-communicable diseases in Syrian refugees, and the reason for that is that before the civil war, Syria was actually classified as a middle-income country with universal health care. So the quality of that health care was quite good, which makes their health profile very similar to that of a Western nation. So we saw a lot of obesity, cardiovascular disease, diabetes, and the key to treating those non-communicable diseases is long-term follow-up and chronic medications, which you can imagine is very difficult to obtain and do while you're on the move in that way. So a diabetic, for example, wouldn't have a way of obtaining insulin or storing it, which it needs to be refrigerated. And their diet is also not regular in order to give themselves regular doses of insulin. Somebody who has cancer, I saw a patient who came from Syria with notes of all of his scans, his CAT scans, detailing his lung cancer, which had spread to his liver, his chemotherapy regimen, which he was getting every 3 weeks. And he had been in Turkey for 3 months and he hadn't received any chemotherapy, so he's almost certainly dead. And then we see a lot of somatic syndromes, chronic pain, fibromyalgia, partly because there's an immense amount of psychological distress. But in Arab culture, a lot of times it's not very appropriate to express psychological distress or seek that type of help. And so it manifests as physical symptoms. In terms of maternal and child health, there's no regular access to contraception, so women do continue to get pregnant. While they're pregnant, there's no prenatal care or way to ensure that the fetus is developing normally. When the child is born, some women do go to hospital to deliver, but they're discharged back to the refugee camp after a couple of days. So you see this woman bathing her newborn child in a puddle in a camp. The children behind her also have not received, and this child will not receive any well child visits or immunizations. And so Syria, which was polio-free for 15 years before the war, has now seen outbreaks of polio. There have been outbreaks of measles in Syrian refugees in Lebanon. And there's also no access to education for those children behind her, so they're not getting an education at all. So that's the Syrian crisis. I want to move on now to a couple other major refugee crises in the world. Has anyone here heard of the Rohingya crisis? Raise your hand. Okay, good, a good number of people. This crisis gets a lot less attention in the media. However, it has gotten more attention since August. The Rohingya are an ethnic Muslim minority in Myanmar who experience persecution from the Burmese government. And they've gotten more attention since a military offensive which occurred in August 2017 that drove about 1 million Rohingya out from their homes and seeking refuge and asylum in neighboring Bangladesh.
I call on the Myanmar authorities to suspend military action, end the violence, uphold the rule of law, and recognize the right of return of all those who had to leave the country.
So this is a picture of Kutupalong camp in Bangladesh, and there are several 100,000 people in this camp, and it stretches for a couple miles in this fashion with huts made of the bamboo forest, which these people cut down in order to obtain shelter. So the typical MO of the Burmese military is that they will come into a village, kill all of the men, gang rape the women, and then abduct the young girls and women for sex slaves. And then often they will kill or burn alive the children in front of the women, and then they'll set the whole village on fire. And so from similar satellite images, we know that over 50% of Rohingya villages have been burned down in this fashion. Those who survive walk several days through the jungle with no food and drinking water from rice paddies until they arrive in Bangladesh, where they can seek refuge. And you can imagine that that type of tactic causes quite a significant amount of psychological trauma and post-traumatic stress disorder. So these are just some interviews from a report where Rohingya refugees were interviewed and described some of their experiences. So their experiences are very brutal. When we provide care to this patient population, one thing that many healthcare providers have noted is how meek and passive and silent these people are. They're collectively traumatized. They come into the patient room and they sit very quietly, no eye contact. They rarely speak. They don't ask for anything. And in many ways, it's reminiscent of treating an abused child. So very disturbing to watch, actually. We also see quite a bit of infectious disease in this population, and again, that's reflective of their medical care before this current crisis. So, you know, the Rohingya have been oppressed and isolated for many decades, and their access to humanitarian and medical assistance was severely restricted. Oftentimes, they were not allowed to obtain an education or work. And so, coming into Bangladesh in a situation of overcrowding of hundreds of thousands of people with poor sanitation and no clean water, that's really a setup for outbreak of infectious disease. So we see a lot of diseases that spread quickly from person to person, like tuberculosis, scabies, ringworm. There's also, they haven't received many of them any immunizations or ever seen a doctor, and so there was a huge outbreak of diphtheria when I was there a couple of months ago, also outbreaks of measles as well. The top picture is of ringworm in a woman who had it all over her body, and usually it's confined to one area of the body, but we often see it in multiple areas of the body in this population. The bottom picture is harder to see, but that's a picture of scabies, which typically you can see it in the interwebs between the fingers. This is my only slide on oral health. So many of the Rohingya refugees, their teeth look like this. Does anybody have any idea what could cause teeth to look like this in a South Asian population? Betel nut, pan. So pan is a combination of betel leaf and areca nut, and it comes in many different flavors. It's sometimes combined with tobacco, highly addictive. People chew it for many hours. And the areca nut is carcinogenic, so it causes not only tooth and gum decay, but it has also been linked to oral and pharyngeal cancer. And so one of the most common complaints that we see in clinic is people coming in with abscesses or broken teeth or needing a tooth extraction. And unfortunately, because there's such a shortage of medical care, most of the care is focused on life-saving care. And so something that causes an immense amount of pain and disability and poor quality of life like this is unfortunately not addressed. So our last crisis we'll talk about today is the Yemen crisis. How many people have heard of this crisis? Okay, good. So fewer than the Rohingya crisis. The Yemen crisis gets almost no media coverage compared to the other crises that we talked about, and yet it's actually the largest humanitarian crisis in the world right now. So you can see that, first of all, it's caused by civil war in Yemen, which has been going on since 2015. And you can see that the numbers of refugees that we're talking about are actually much smaller than the numbers in the other crises, right? So, and most of those refugees aren't even Yemeni. The Yemenis are the ones in dark blue, which is not many of those people that you're seeing. But what this figure doesn't tell you is that actually there are 3 million internally displaced in Yemen. So people are hugely affected by this civil war, but they are not leaving. And if you're wondering why, it's because they can't. And the secret to that really lies in geography. So Yemen is mostly surrounded by Saudi Arabia, and the Saudi-led coalition is actually supporting the airstrikes on Yemen, so people can't leave to Saudi Arabia. And they also can't leave by sea because the Saudi-led coalition has also placed a blockade on any movement by air, land, or sea. And so the main international airport, which is Sana'a, is closed. The ports, which are how most goods come and go, are also closed. And as a result, millions of people are internally displaced. So, a disturbing picture, but what that blockade also means is that no food can get into the country. And for a country that imports 90% of its food, that is absolutely disastrous. In addition to not being able to import food, airstrikes have targeted farming infrastructure in addition to economic infrastructure, and you can't get fuel into the country, which means that even the farming infrastructure that has survived the airstrikes can't run and farmers can't grow crops. And so as a result, there is rampant food insecurity. 18 million people are food insecure in Yemen, including 1.3 million children who have acute severe malnutrition. So if you look at the 3-year-old child on the left, you'll see that not only does he have extremely low birth weight for his age, but his growth is stunted, so his height is low. He has muscle wasting. He doesn't have any muscle. You just see skin and bones. And in malnutrition, what we measure is the median upper arm circumference. And so if that is less than 11.5 centimeters, that child meets criteria for severe acute malnutrition, which is certainly the case in him. On the right is a child named Uday Faisal, 5 months old, also with severe acute malnutrition. His parents brought him to one of the few remaining open health facilities in Yemen. Over half of those facilities are now closed. And they did attempt to treat him, but just as his parents could not afford food, they also couldn't afford the medical treatment. And so they took him home and he died a couple days after this picture was taken. There is also right now going on in Yemen the largest cholera outbreak in recorded history. So over 1 million cholera cases in the past year. Cholera is a diarrheal illness, so that's spread by fecal-oral transmission. So the real key to preventing cholera is clean water and good sanitation with proper disposal of sewage. Because of the lack of fuel, the way that people get clean water in Yemen is they pump it from the ground. And so if you don't have fuel, you can't pump clean water. So there's no clean water. People are drinking contaminated water, and they also can't boil the water to sanitize it because there's no fuel. And then when they develop diarrhea, the economic infrastructure and sewage systems have also been targeted by airstrikes. So the main sewer in Sana'a is not working as well. And so there's no proper disposal of sewage either. So that's essentially a setup for major catastrophe, and that's part of the reason for this outbreak. The other thing to mention about this is that this epidemic has been identified, and non-governmental organizations do want to come in and help, but because of the blockade, they're not allowed to come in to provide medical care. They can't get medical supplies in, and those few organizations that have been let in, like Doctors Without Borders or MSF, 4 MSF hospitals were targeted by airstrikes in a 12-month period. So it's a real disaster. And I didn't mention this, but of the 29 million population, 22 million or 75% require humanitarian assistance right now, and that's really what makes it the largest humanitarian crisis in the world. So we talked about 3 very different refugee crises: the Syrian crisis, the Rohingya crisis, and the Yemen crisis. I hope that one of your takeaways is that every refugee crisis is different, and every crisis deserves culturally competent intensive study within its own context. There is no one-size-fits-all approach to refugee health. Not only that, but health issues depend on the pre-crisis health profile of the population. So Syrians have a high burden of NCDs because they had universal health care. Rohingya have a high burden of infectious disease because they didn't have a lot of health care before their crisis. Health issues also depend on the mechanism of damage inflicted. Rohingya have a high incidence of psychological and traumatic morbidities because of the experiences that they have had in their conflict. There's a lot of interplay of ethnic, religious, cultural, and geographic factors, as we saw. But ultimately, when we look at the root causes of these crises, it's important to know that they're mostly driven by socioeconomics and politics. And so you don't have to be a doctor to be involved in these crises or try to address the solutions. I really hope that some of the things that you've learned today have sort of inspired you to consider your own role as a witness and as an activist, because as citizens of the most powerful and richest country in the world, the fact is that we are involved in a lot of these crises, and you do have a say. So I'm going to move into the second part of my talk and talk a little bit about our work here at UCSF and my work as a physician in the refugee crisis. I mentioned that I started as a volunteer working in the Syrian crisis. So I did boat rescues on Greece, in the Greek islands, and then on mainland Greece. I also worked along that Balkan route that I described to you in Eastern and Western Europe, and I worked in the Middle East as well. And at some point, I really had to stop, like many volunteers, and ask myself, what are we really doing? And the reason I had to ask myself that question is that I saw a proliferation of non-governmental organizations and volunteers, and I saw the immense amount of money, donations, time, and energy being put in by the NGOs and volunteers, but I wasn't always sure of the results and of the impact that we were having on refugees. I really had to critically question the work that we were doing. One good example is this picture of this suitcase of donated medications. So the NGO I was working for had at least 10 similar suitcases of donated medications. It's full of expired medications, medications I've never heard of, medications that treat conditions that we weren't even seeing in the refugees. I think we had like 5 donated nebulizers, but no nebulized medication. And all of the nebulizers needed to be plugged into the electricity, whereas these people were living in camps. And so there was a really serious mismatch and a lot of redundancy between what was being provided and what was actually needed in real time. And what made it worse is that when I was asking myself these questions and searching the literature for evidence that these kind of interventions worked or kind of the impact that they were having on our target population, there was just no literature available, and kind of issues were not really studied. And working at UCSF, where we have a really important focus on quality of care and quality improvement, that was very disturbing to me. And so that's kind of how I got involved in refugee health. As many of you know, in the rest of medicine, we practice evidence-based medicine, which means that when we see a problem, we ask a clinical question, and then we do research to study the answer to that question. We analyze our results, and then we apply it to our population and see if it worked. And yet somehow when it comes to refugee health or humanitarian work, that whole approach of evidence-based medicine just kind of flies out the window. In favor of these quick Band-Aid interventions that address the perceived urgency of the situation and the severity of the crisis, and yet they're not really sustainable in the long term. So we spend most of our time putting out these fires because we feel that there's a great need and immediate urgency. But if you really step back and think about it, so the Syrian civil war has been going on for 7 years, the Yemeni war has been going on for 3 years, and there's 1 million Rohingyas in Bangladesh that aren't going anywhere anytime soon. And what that means is that when we're trying to treat these populations with no data and no evidence base, we just don't understand the clinical issues that we're facing. And what that means is that we are providing substandard patient care, and that's leading to poor health outcomes. Even when we have the best of intentions, sometimes the road to hell is paved with good intentions, right? So we have to be really critical about the work that we're doing. Those kind of short-term approaches really neglect sustainability, efficiency, self-evaluation of our work, and especially the views of the refugees themselves, which I'm amazed to see almost nobody asks that question. So at Rahi, we're really trying to work to change that narrative of refugee health to make it more evidence-based. Our mission is to improve the health of refugees, and we envision doing so by developing sustainable, evidence-based interventions that improve the quality of refugee healthcare via our own original research. We have 4 core foundations, as I mentioned. We do believe that doing research in this field will ultimately lead to improved clinical care, but we also have branches in community education and community involvement and education. So there are a few different projects that I'm principal investigator on. So one of our projects is in a group of Syrian refugees that lives in a Palestinian camp in Lebanon. And we will be presenting some of that work at the North American Refugee Health Conference next month. And the other is a needs assessment of Rohingya refugees in Bangladesh. We do think it's really important for our teams to be sort of culturally and linguistically congruent with the populations that they're serving. And so, for example, our team working with Syrian refugees is mostly fluent in Arabic. We also foster a lot of research and development of research teams here at UCSF by connecting people in different fields. And that includes both local and international research. And then we're involved in the sort of development of this novel education on specifically refugee health in the Middle East. So we're developing an online course with UC Berkeley, which will be free and open to the public if people are interested in learning more. That should be launched next spring. In terms of clinical care, we do provide clinical care to refugees and all newcomers at San Francisco General Hospital, which is where I work. There's a refugee clinic there, and we also perform medical asylum evaluations at the Trauma Recovery Center as well. And so those are for individuals who are seeking asylum in the United States. So many people ask how they can get involved after hearing this talk. There's a couple different ways. So the North American Society of Refugee Health Providers is fantastic, and they hold an annual conference every June. This year, for the first time, it's going to be on the West Coast in Portland. And I think also Physicians for Human Rights and Doctors Without Borders, or MSF, are great organizations to get involved with and support. If you'd like to get involved with us, we do have a listserv. You can email us, rahi@ucsf.edu. If you have an idea for a new project or collaboration, we are always open to that, with the caveat that you be ready to lead your own project, because we do have a lot of volunteers, but not enough people who are able to lead those projects. And students can be PIs as well, just FYI. If you'd like to donate to us as well, we don't have any funding for any of the work that we do. My regular job is that I'm a doctor, and I do this in my free time. So we have a crowdfund page as well. Thank you.
So how do you deal with the sort of politics of these areas when, you know, I assume that you're going into them yourself? Mm-hmm. And I imagine that, you know, from the outside, we don't always hear exactly what's going on. You know, you might see a news report, but we don't know who wrote that and where they got their information from. How do you deal with all of that, those unknowns? Thank you.
Thanks for your question. I think the most important principle of what we do is that we believe that everyone deserves health care, and that's sort of regardless of political affiliation or ethnic group. And so in a lot of ways, that does make us very neutral, but you're correct that navigating the political situation can be very difficult. And a lot of times there's a lot of nuance there that you don't realize just from the media. A couple things that have helped us is, as I mentioned, we try to have our research teams be from the same or similar culture. So for example, I'll give you an example of our project in Beirut. So we are studying a group of about 20,000 Syrian refugees that live in a Palestinian refugee camp that contains like another 20,000 Palestinian refugees in Beirut, in Lebanon. And there's a lot of social tension between those Syrians, those Palestinians, and those Lebanese, which you wouldn't immediately notice if you weren't from that group of people. So it has really helped that I'm Lebanese to be able to navigate that situation and get access to that population. And I don't think that if somebody was not Lebanese that they would necessarily be able to do that research without making a lot of people very angry. So I think that's probably the biggest thing that helps. The other thing that came up was with the executive orders and the refugee bans and the Muslim bans. That was around the time that we were kind of starting a lot of our projects. And so many people on our teams are resettled refugees or immigrants. And so that made it very risky, and especially getting approval for students and residents to travel to countries like that, it required a lot of maneuvering. We don't go to active war zones. So for example, we wouldn't go into Syria, nor would that be safe to do. We wouldn't, and that's also the reason that we haven't been able to provide any care in Yemen.
I came here from Minneapolis, and we worked with the Somali refugees. And I was so glad you brought up the Rohingya behavior, because we saw the same thing. It seemed that it develops into a chronic refugee state. And I would like you to comment on the chronic situation of refugees and the social determinants of health in that group.
You mean in refugees here in the United States?
Sure, that once they come here, they're in the East Bay perhaps, and Asian Health has so many of these patients, and they have major psychiatric issues and social determinants. So I wanted you to comment on chronicity and refugee status.
So when refugees are resettled here with their families and then they have children here, it becomes such a complex social situation because they are a minority population and they are disadvantaged. And that's not just from the perspective of medical comorbidities, but also from psychiatric comorbidities. They're bringing that trauma with them. And those psychological comorbidities really complicate a lot of their medical care. So you can imagine that coming to a new country, not knowing how the system works here. I mean, lots of us as Americans can't even figure out how the medical system works here, right? So asking a refugee to enroll in Medi-Cal and figure out which clinic to go to and how to navigate public transportation, that's a monumental task. And so there's a lot of culture shock, but also they don't have the language, and they're often coming from a different religious perspective as well, which impacts their views on health. So I would say that more than half the battle is really establishing rapport and being able to help them navigate those day-to-day tasks. When refugees are resettled, they do initially get a few months of support from refugee resettlement organizations like the International Rescue Committee, for example, or Catholic Charities or Jewish Family Services. But if you think about if they get 6 or 9 months of support, if you move to a completely new country with a different language, would you be ready to go solo after 9 months? It's pretty tough, and it's also complicated by the factor that it's often very difficult for them to find adequate employment as well. So, and then I think I mentioned this briefly in the Syrian refugee population, but in some groups and ethnicities, it's not really considered culturally acceptable to express psychological distress. And so they don't have often a great framework for expressing the impact that trauma has had on their lives. And so that manifests itself as, for example, chronic pain. Like we see many young women with chronic abdominal pain, for example, and they get lots of different tests that are negative. And then ultimately, sometimes we do, after we've ruled out the dangerous things, realize that it may be related to their psychological distress. So caring for these patients can be very challenging and much more complex than others, but it's also extremely rewarding.
Right. Well, thank you very much. To introduce our next speaker was going to be Dr. Jeff Eaton, who unfortunately cannot make it here today. A situation arose that prevented him from being with us. So instead, I'd like to invite Dr. Steve Silverstein to share a few words about the community dental clinic at the UCSF School of Dentistry, and then provide an introduction for our next speaker. Thank you.
Well, I was minding my own business sitting on a bench in front of the dental school having lunch. Dr. Eaton came by. He says, "Can you help me out? I can't be at the Global Oral Health this afternoon because I have a conflict. Can you introduce Arvin, our CDC director?" I said, "I'll be glad to do that." I forgot my Nordstrom suit, so here I am. But just a little background. This is all about Arvin, not me. But in 1994, 4 of our senior dental students came to me and they said they'd like to provide dental care for the homeless. And this was at the 5th and Bryant shelter downtown, a city shelter. They said, "The medical students are there. Where are the dental students?" So I said, "I'll be glad to help." And here we are 25 years later, just with a wonderful program. As far as personal satisfaction, I'm now emeritus at this dental school, was serving as the faculty director of CDC up until Dr. Eaton took over, meeting all the wonderful students, student directors, etc. It was just enlightening for all the young people that brought new energy every year. We stay as faculty, but the students come and go, and this new energy is just incredible. So that's what keeps it going. So this will be the 25th year. We've had support from all the deans, all the associate deans, the clinical directors, the department chairs, the chancellor. It runs on almost no money. They get some funds from the student associations and a few donations, etc. All the faculty in the evening are voluntary. That means if you have an 8 to 5 appointment here, you go to CDC in the evening, that is extra and on your time. And the wonderful faculty have been providing supervision for the students over the years. When I started this in 1994, I needed a faculty member. Who showed up? Dr. Eaton. So he was the first volunteer faculty member in 1994 that says, "How can I help?" And when I went emeritus status in 2014, he took over as CDC director. So we have to thank Dr. Eaton. Okay. So I want to introduce, it was just wonderful that you've included this activity into your global oral health program. This is Dr. Eaton's speech in his words, that he wanted to thank Dr. Chaffee for inviting the CDC program to speak before you today. It's a great honor. And that this program has been a student-created, staffed, and driven program. It's only fitting that future Dr. Powell speaks to you and elaborates his function here at UCSF. I haven't met him. Where is he? Oh, hi. I've seen his YouTube videos. I've seen his videos from the Chancellor's PR campaign, so he's been everywhere. And he came up with an initiative, and again, Dr. Eaton sends me the emails because I'm still very engaged with this, that he wanted to start a new program. Each year, the student energy, they all come up with something new, and this was very unique. So Arvin approached Dr. Eaton last year in the School of Administration with a bold new idea, to be able to offer services to undocumented persons and to political refugees, to the battered women's shelter, and to several more groups through the city in desperate need. The bold proposal was unheard of in the scope and required getting not only permission to expand what patients are accepted, but also be able to use more of the school's facilities to do so. It also required many more faculty to commit volunteering to supervise it. Arvin was very successful in securing all these things and more. To date, the program has delivered in excess of $1.5 million in free care. It has won numerous awards acknowledged by the ADA, the CDA, the mayor, and the governor of California. We just received awards for public service. We believe it's the largest dental school-based program in the country. And I've heard from a number of pre-dental students and first-year dental students. I came to UCSF because of the volunteer programs at UCSF. And this is Dr. Eaton, and it holds true for me. Personally, it has been one of the most meaningful and rewarding experiences of my career, and I'm deeply honored to be able to work with such gifted students, and I second that. And so I'll introduce Arvin, and he will share with you his new initiative for refugees, battered women, and he's going to pass it on to someone else. Thank you.
Okay, hello everyone. My name is Irvin, as you just heard. I'm a third-year dental student here at UCSF, and up until last month, I was the student director of the Community Dental Clinic, also known as CDC. So just before I get into what I've done with the clinic, I'll just talk a little bit about my background. That pictured is Dr. Eaton, who couldn't be here today. He's a little shorter than me, but so my background in undergraduate, I actually studied business, which people find really weird given that I spend so much time giving out free dentistry now, or trying to. But I quickly realized after studying business that making money and like serving myself to just build a big bank account wasn't for me at all. I really wanted to get out there and help people. And that's the reason I chose dentistry as a career. So before I came to UCSF, I went on a global brigades trip to Honduras, and upon return from there, I wanted to do things locally, so I started volunteering at the Berkeley Free Clinic, which has a dental section that gives free lifetime dental care to its patients. Eventually, I found myself here and was elected as the director of CDC in my second year at school. You already heard a little bit about CDC, but it is the largest and most comprehensive student-run free dental clinic in the entire country. We provide over $100,000 of free dental care each year to our patients, and to date, after 25 years, it's been well over $1 million. After recent expansions, we typically have about 45 student, faculty, and resident volunteers who come to our clinic, and it's every Wednesday night held here on campus. And as Dr. Eaton and Dr. Silverstein wrote in their speech, it is entirely student-run. So I'm the student director. I have a team of student coordinators who work with me. We select the patients, schedule the patients. The student providers, fourth and third year students, do the actual dental procedures themselves. And first and second years are the assistants. Our typical CDC patients, at least when I took over as director last year, we'd see patients from homeless shelters, rehabilitation centers, women's shelters, and this was only on a referral basis. We weren't a walk-in clinic. But the overarching rule for patient selection at CDC is that these are patients who do not have insurance. They don't qualify for state-aided assistance. In here, California, it'd be Denti-Cal. So these are truly people who have nowhere else to go for their dental care. We're lucky enough to have a team of specialists, either residents or faculty, who come to help us, including endodontists, prosthodontists, periodontists, and oral medicine specialists, who allow us to give completely comprehensive care to our patients. The typical exams and x-rays, but also cleanings, fillings. We work with labs that donate crowns to us. Prosthodontists come and make our patients complete dentures, which is always very impactful of somebody going from edentulous to dentulous. We recently started offering implants to certain patients and do periosurgery such as crown lengthening. and even molar endo with our endo residents. So truly anything that a patient could possibly need, we try to have it here at CDC. So one day I was browsing my Facebook news feed, and I came across this link that was posted by one of my classmates actually, who himself is an undocumented immigrant as a dental student here at UCSF. And I saw the Berkeley Free Clinic. I was like, oh, I used to be there. And then I clicked the link and I see that they just started seeing undocumented immigrants. This was last year, shortly after I became director at CDC. And it really made me think about the word community dental clinic. And I said before, we're seeing people from homeless shelters, rehabilitation centers, etc., but we didn't have any outreach to undocumented immigrants or refugees. And to me, to truly be a community clinic, we need to see everybody in the community. It really made me think, especially because at the time, and even now, you always see on the news undocumented immigrants or refugees are welcome to scenes like this. And it made me think, how would I feel if I was an undocumented immigrant and I had a toothache and I wasn't covered by Denti-Cal? Would I be able to get treatment? Would I know where to go, or would I be able to afford it? So I wanted to make sure that we could do our part here at CDC to see these patients. Admittedly, I was a little nervous about bringing the proposal to the leadership team. At the time, it was Dean Featherstone was in charge, because I was asking for money from a public school to take not necessarily a political stance, but it is a politically heated issue. To me, however, as I wrote in my proposal, I think I'm not taking a political stance on this myself. I just think it's a human issue. If somebody comes to a first world country and they're in pain and we don't help them, to me that just didn't feel right. So I wrote a proposal to see these patients, and it was unanimously approved by the leadership team here at UCSF, School of Dentistry, and even at the highest level of the UC system, I was able to present this initiative at the Regents meeting last year in the summer, and even Chancellor Sam Hoggood celebrated this achievement. So once we decided that we could see these patients, I wanted to learn a little bit more about them. As you see here, most of the undocumented immigrants in this country are from Latin America, especially from Mexico. Very few of them would be considered pediatric or geriatric patients. Mostly are middle-aged adults. And 49% of them do not speak English very well. So that was a challenge for CDC because we didn't have a ton of Spanish-speaking providers or assistants. And 75% of those immigrants speak Spanish. So those were some of the challenges presented to us. And as I said before, the overarching rule for who can be a patient at CDC is determined by if you're covered by state insurance or not. And none of the 11 million adults, and that's a countrywide figure for undocumented immigrants, were eligible for Denti-Cal. Luckily, at least in California, is one of the few states where their children are covered. So this is mainly an initiative for adults. Similarly, refugees. The most common health problem in refugee children is actually oral abnormalities. And for adults, it's the second most common problem. And for refugees, a little more unclear whether or not they're covered by state insurance. It could be depending on which country they came from, whether or not they qualify, or if they do qualify, it may only be for 12 months or less. And as our previous speaker was just talking about, that may not be enough time if you come just straight from a different country, don't speak English, you have to find a job and secure health care within a year or less is a lot to ask. One of the challenges I actually had once we started reaching out to these refugee centers was that not a lot of refugees were prioritizing their oral health. Certain demographic groups actually came to this country with good oral health because their diet in their country of origination was low in refined sugar. However, they are susceptible, research has shown, when they westernize their diet, eating more of the processed foods, refined sugars, to getting more poorer health, oral health, especially if they don't have access to dental care when they come to this country. One study actually found that refugees rated their own oral health quite highly, but upon clinical examination, 80% of them had untreated periodontal disease or caries. Of course, this is understandable when you consider the environments these patients are coming from. They have to prioritize their own safety and health or survival over their oral health problems. However, that did lead to the low rate of utilization of services when they came here. And that was something that I've been personally trying to do in this past year. It's the new program, is trying to make sure that these people realize that they have health problems and that we can help them. So that's kind of been the difference between treating undocumented immigrants and refugees. The undocumented immigrants seemed more aware that they needed dental care and they were motivated to come in. Of course, they did need interpreters. Whereas the refugee centers I contacted, for one thing, were much further from San Francisco. Some of them were covered, some of them were not. But the main thing was that we need to go to them and do screenings to let them know what kind of treatment they need. Just some general considerations. What I've noticed from treating this population is that we don't ask for any information that they're not willing to give us. If they don't want to tell us officially on the record that they're an undocumented immigrant, we don't force any questions on them. Of course, coming from different countries, there'd be different cultural things you need to be aware of. We really try to reinforce the U.S. oral hygiene standards so that they have preventative care. And one of the main problems, to be honest, is a lot of these people are working multiple jobs. They may may live like an hour from San Francisco, don't have a car, and just simply don't have time because they're always working to come get dental care. So that has been the main problem I've encountered treating this population. In the future, so I'm not currently director of CDC, but the new director, Angela, is working on new projects, which include actually going to migrant farmers in the Central Valley of California to have mobile clinics there. We're trying to find more reliable referral centers which can send us patients without having empty chairs. Because if we schedule a patient and they don't show up, that's very unfortunate because that's another person we could have helped who we couldn't. We're in the process of securing translators. Hopefully, ideally we'd get first and second year students who speak Spanish to come help us, but we're also talking with pre-dental organizations. And we've considered using transportation vouchers to help people who maybe don't have a car to get to our clinic. In closing, I just want to share a few stories with you about what kind of patients we've seen at CDC. This is actually a scene, it's like our pre-clinic huddle that Dr. Eden has with all the students before patients are seated. It's really an inspiring moment because you see all these students and faculty who come to our clinic at 6 o'clock after working 8 to 5 that day, and maybe probably have to wake up and do the same thing tomorrow. But they still come and are very happy to be here. Nobody's here who doesn't want to be there. But an example of an undocumented immigrant, and actually a similar situation I've seen multiple times, is we had a boy who was 18 years old. Actually, really, he was a young man, if you consider his experiences. He came from Mexico, where he was addicted to crystal meth, and he's actually immigrated to this country illegally by himself without his parents. So he didn't have a job, he didn't have money, he didn't have anything when he came here, and he had a lot of oral health problems. They're like stopping him from moving forward with his life, finding a job, and basically restarting his life here in the US. So we're able to get him out of pain and get him on the fast track to getting a job and doing all of those things. And he was very appreciative of what we were able to do for him. Another example, one step further than that, is we had a young man who came in. He was very shy, didn't smile very much at his first exam appointment, and he had a long treatment plan. It took about 9 appointments. And I still remember very vividly on his last appointment, he had been working with the same student dentist each time. And she finished his last composite restoration and he started crying. And she asked him like, what was going on. And he said when he first came to our clinic and for years prior to that, he hadn't had a job because he was very self-conscious about the way he looked. Whenever he got job interviews, he just didn't feel confident that that he deserved to be hired at all. He had gotten in and out of jail and all kinds of problems just because he didn't feel like himself. And after all of our dental work that transformed his smile, he felt like himself again, and he let that student know that he actually interviewed for a job a few days prior to that last appointment, and he got a job for himself. So we were literally able to get this man a way to sustain himself again. And that was very rewarding. And that's really what this clinic is about. I always tell our students, you're only going to be here at the CDC for a few years, but I really hope that it plants a seed in your mind that you can understand the need of the population out there who doesn't have insurance, who has nowhere else to go. They will always be the most appreciative patient you have. And if CDC can even produce a few students who go on to have long 40-year careers in helping people in their free time, then that will truly be the greatest success of CDC. And with that, I thank you for your time, and any questions, I'll be available.
Thank you. I wanted to ask you about the coverage. There seems to be the presumption that if you have coverage that you don't need these other services. But do you know that UCSF Endodontist does not take Denti-Cal, to which I was referred by my student dentist, and I called Denti-Cal, Medi-Cal in Sacramento, and they said there is no one in the city of San Francisco that is on their computer as providing endodontic services with Denti-Cal coverage. So do you have any ideas about how, like, what could be done to advocate that UCSF would include endodontics in their Denti-Cal? I couldn't believe it, right? I mean, my son was born at UC. I mean, they take Medicare, Medi-Cal, the whole thing, and I didn't know that endodontics was excluded. Anyway, do you have any ideas on how that could be opened up to Denti-Cal patients?
Yeah, so I actually run into the same issue. I'm a student provider myself at the dental school, and I refer patients. So the reason we don't accept people who have Denti-Cal at our clinic is because most general services like exams, cleanings, fillings, extractions are covered at the school for no cost to the patient. But we do run into this issue where a patient needs specialty services and they're not able to be seen covered by Denti-Cal. There is an initiative, at least at our school, I know it's probably not statewide, where certain fourth-year students, if they have enough experience in endodontics, can treat patients who would typically need specialty care, and there's a possibility where they're pre-authorized by Denti-Cal to do that procedure with coverage. But of course, that depends on the simplicity of the case. In terms of a wider scale solution for everybody, I can't say that I have any solution for that. I do wonder if there's any possible relationship that CDC could make with other organizations. Maybe patient does have Denti-Cal, but they can't afford specialty treatment if they could come to see us. But that's a conversation I'd have to have with people higher up than me.
The refugees, after they arrived here, they all go under the Denti-Cal coverage. So before the Denti-Cal come to California, after 8 months, they don't have any health insurance after that. But now, because they mostly are not going to reach the income point of not covering by Denti-Cal, they are staying by Denti-Cal. So if you don't accept Denti-Cal people here, they cannot utilize it. As I used to work in the resettlement center in Oakland, and we have this problem all the year round. So because they all have the Denti-Cal, they cannot utilizing the CDC. If the initiative that you talk about it and approved here going to be effective, so these people, they all have Denti-Cal.
So, like I said, it does also depend on which country they're coming from, but you're right, a lot of them, when they come, they do have Denti-Cal. So one of the things that we're trying to do when we go have screenings at these places is to make sure that they know their options of where they can go if they have Denti-Cal and they want treatment. We don't just say, oh, you have Denti-Cal, we can't treat you. We give them a list of places they can go, including UCSF itself during its daytime clinic is always accepting Denti-Cal patients. So does that answer your question?
Yeah, but it's the only, as she mentioned, the only problem that is not going to, for example, they all using Highland Hospital in Auckland, but because it doesn't do the endodontist, they all just ended up with extracting their tooth. So most of the refugees that we see, they are coming with tooth extraction. This is the only, because Denti-Cal covered is free tooth extraction for them, so
Right.
most of them ended up with tooth extraction.
No, that's a very good point, and also echoes the previous comment, which I think this program I've started does need expansion, and definitely in these things that you're talking about of how we can get specialty services to people who already are covered for other services. So that's something that is definitely room for us to grow.
Thank you.
Yeah, thank you.
Thank you. So one part of our symposium every year is we've been happy to have lots of support from organized dentistry, from the American Dental Association, the California Dental Association, and this year is no different. We'll have a presentation from a representative of the CDA, and to introduce that speaker, I'd like to call up one of my colleagues and faculty members here, Dr. Lisa Chung.
Thank you, Ben. Good afternoon, everybody. I'm delighted to present our next speaker, who's also my friend and colleague, Dr. Irene Hilton. Dr. Irene Hilton is a public health dentist at the San Francisco Department of Public Health. She's also dental director at the Silver Avenue Health Center, which is part of the San Francisco Health Network system of clinics. She received her dental degree here at UCSF, her MPH, Master's in Public Health from UC Berkeley, and completed her dental public health residency also here at UCSF, and is board certified diplomate in the specialty of dental public health. She has served as dental consultant for the National Network for Oral Health Access, or NOAA, for about a decade. And it's a national organization of oral health providers in the federally funded health centers across the U.S. She is a clinical instructor in both UCSF School of Medicine in the Department of Family Community Medicine and also in the UCSF School of Dentistry. In fact, she's going to come lecture to our first-year dental students tomorrow. She is PI of the Dental Transformation Initiative with San Francisco Department of Public Health as the lead entity, which brought in $6 million over 4 years to increase participation in Denti-Cal among both providers and participants or patients, with the ultimate goal of improving the oral health of our San Francisco Denti-Cal Medi-Cal population between the ages of 0 to 5. She's also past president of the San Francisco Dental Society. So as you can see, she serves many different roles as a public health dentist, but today, right now, she's going to speak on, she's going to represent her role as the current CDA trustee from San Francisco. So without further ado, I'd like to introduce Dr. Hilton to the podium.
Thank you, Lisa, and it's nice to see so many friends in the audience. I can now reveal that Mark Kirkland and Jeff Eaton were in the same class in dental school, which was one class ahead of me. I could date myself. So it was really interesting to hear those comments about Medi-Cal and adult Medi-Cal and the coverage of root canals. And if you ask me again in the QA, I will help answer that question from a systems perspective. That again will show us how far we need to go. First, I want to say that I bring you greetings from Dr. Natasha Lee, who is the current CDA president, who is actually from San Francisco, practicing dentist here, although she did go to the other dental school, is not able to attend and asked me to present in her place. So when I was asked to give this presentation, they asked me for my title. So I decided to go with The Window of Opportunity for Oral Health, which probably should be subtitled, There's More Money Than Ever for Dental in California right now So we better use it wisely while the window is open. Okay. So, and I was trying to figure out how to tie this really interestingly with Fatima's great presentation on refugees and the things that they go through. And I guess I will try to tie it in by saying that if you manage to make it to the United States and to California as a refugee, especially as a child, and you get your Medicaid benefits that includes dental, what would be the situation that would confront you in attempts to access care? So let's go to 5 years ago. Okay, 5 years ago, we had no state oral health infrastructure. We did not have any dental surveillance. We wouldn't be able to tell you how many kids had how many cavities anywhere on a statewide level. We had no state dental director. At that time, 5 years ago, which would have been 2013, we had no dental benefits in Medicaid in California because they had been cut out in 2009 after the economy tanked with the housing crisis. The Medicaid reimbursement rates in California was 29% of UCR, one of the lowest in the country, percentages in the country, which of course, would lead to, even for kids that were covered, less than half of kids in California had a dental visit with a dentist in any given year during that time. Today, through the efforts really of everyone, not just organized dentistry, but all public health advocates in the community, and yes, the economy has improved. Again, we have this window where we could be kind of in a golden age where there's a lot of money and funding available for dentistry and oral health right now, and it's incumbent to make sure, like I said, that we spend it wisely and get the most long-term investment to improve the oral health of everyone. So just a little explanation, again, with my CDA hat on. It really started in 2014, when we had the partial restoration of the adult Medicaid benefits. The root canal was not one of those procedures at that time. And that was partially due a little bit to the efforts of CDA. After benefits were eliminated in 2009, CDA, through the CDA Foundation, started sponsoring these CDA Cares events twice a year in different parts of the state. And for those of you not familiar, these are these Mission of Mercy type events where all these volunteers come together and thousands of people come and wait in line for hours and days to get free care. And when they had that event in Sacramento in 2012, they invited, at the time, Darrell Steinberg, who was the president pro tem of the California State Legislature, who was shocked by the number of people that were standing in line that were unable to get health care and the needs that they had. And he actually, at that time, started then to advocate. It took 2 years, again, in a whole collaborative, to do that partial restoration of the adult benefits. And actually, this year, all the benefits have been restored. However, of course, the root canal for the adult is still not a benefit. So that's a systems issue probably for another day. So after that, the following year in 2015, we had the appointment of our first state dental director in, I want to say, about 20 years, Dr. Jay Kumar. And Dr. Jay Kumar is actually was the long-term dental director in New York State for over 20 years prior to coming here, and probably one of the top 3 state dental directors in the country in terms of his ability to understand the big picture. And his hiring was actually, again, CDA partially, part of the collaboration. In 2012, at the request of the CDA House of Delegates, CDA staff, after many years of work, prepared what we call the Access Report that has a bunch of strategies for increasing access to dental care in California. But the first strategy was to create an oral health infrastructure. And again, CDA, through its lobbying efforts and work with the legislature, we were finally able to get funding, like I said, to hire Dr. Kumar, and kind of started us on that way. And he has spent the last several years developing a 10-year oral health strategic plan for California that was just released in January. And he'll be able to leverage, funding at the federal level, again, to increase the infrastructure, oral health infrastructure in our state. Next, the following year, in 2016, CDA was one of the co-sponsors, along with California Medical Association, Hospital Association, of Prop 56, which was the $2 tobacco tax, per pack tobacco tax, and there had been years, I think decades, since there had been an increase in the tax, and of course, there was a huge opposition by the tobacco lobby, but the proposition did pass, and that funding and at the moment is being used. Among the things it's supposed to go to is to increase the reimbursement rates for Denti-Cal and Medi-Cal procedures here in California. So currently in 2018, for this year, Denti-Cal reimbursement rates have been increased by 40%. Okay? Now it's a year-to-year thing, so it could go away, but like right now is 40% over what dentists could get in 2017 for reimbursement. So hopefully that'll help. Another pot of money of that Prop 56 money, $30 million is going to the permanent, yearly permanent creation of the dental public health infrastructure here in California. So Dr. Kumar is going to be able to hire several epidemiologists and more staff to, again, like I said, create the infrastructure and do surveillance, on oral health. A part of that money, $18 million, has been carved out and is going to every county prorated based on the population in the county, and is specifically supposed to go for dental public health infrastructure. So for example, in San Francisco, I think based on our population, we've gotten a couple of $100,000. This is through the Department of Public Health. We have hired a full-time dental epidemiologist and a trainee, and we've done some funding for some task forces to do some messaging and other activities. So we have already started to use our money, and all the other counties in California are going to be getting the same money. And in fact, UCSF and Dr. Silverstein has a separate contract with the state to do technical assistance with the counties to help them develop their strategic plans and infrastructure. So again, this opportunity is like right here, right now. Now, on top of all that, between 2016 and 2020, California right now is in the middle of a 5-year Medicaid waiver from CMS. Now, the sad part of it is that I backtrack. Dental is part of that waiver. It's called the Dental Transformation Initiative, and that's the DTI that Lisa was referring to. The sad part of it is that, California's Denti-Cal situation was so bad, that CMS basically had to insist that our waiver not just include medical and hospital services, but also include dental. And so it does. So there's this huge pot of money, I think it's $740 million, that's going to go, again, to the purpose of increasing Denti-Cal utilization in California. So some of that money, or most of it, is going to provider incentives. Okay, so again, in between the 40% increase from Prop 56 and the provider incentives, again, there's more money at least going into so that individual providers will join the program or rejoin the program. There's also a small pot of that money that's actually going for local dental pilot projects, and this is the funding that we applied for with the Department of Public Health as the lead entity in a huge collaboration with the school district, UCSF, community task forces, San Francisco Dental Society. We applied and got our $6 million to enable us, again, to do a series of pilot projects that we hope will, again, increase Denti-Cal utilization for our population of focus, 0 to 5-year-olds, but also improve their quality of life and their oral health status. So lastly, and this is San Francisco specific only, can I put my, see, it's either see the paper or see you. Okay, now you can see you. I also want to, let me finish up this piece. As you know, in 2016 here in San Francisco, we also voted in the soda tax, right? It's going to generate $10 million, basically, for 2018-19. The collection of the soda tax started in January 1st of this year. And like I said, we run on the budget year from July 1st to June 30th. So for, starting July 1st, it's going to generate $10 million worth of revenue, okay? The legislation that created the tax also created an advisory committee of 16 people, which was supposed to give recommendations to the mayor and the board of supervisors about how the tax is going to be dispersed. And so that advisory committee currently, which I happen to be a member of, has recommended 10% of the tax, or $1 million, go to oral health, here in San Francisco for various preventative activities, the primary of which we hope to do is increase our school-based sealant program for us. So in conclusion with that piece, there's more money floating around than there's ever been We don't know how long it's going to last, but really it's incumbent, on everyone in this room and all the community and everybody to stay on it and hope that we can set up some infrastructure that, again, will last way beyond as the economy goes up and down. For that future. So that's the CDA hat. Okay. I also have to say that this is the first presentation I've done since 1992 where I have not used a PowerPoint. Okay? Because it was, thank you. Yeah. It's a crutch, man. It's a crutch. I was like, no. But, I figured for 15 minutes I could do it. I know I have 3 minutes left. So I just wanted to actually finish up and do the personal story piece, right? I mean, when I saw that the topic was going to be refugees, immigrants, asylum seekers, unless we're descendants of the indigenous people of North America, we're all either immigrants or children of immigrants or refugees. I'm no different. I'm first generation. My mother was an economic immigrant from Guatemala. They came to this country in the 50s. My father was a refugee who left Nazi Germany in 1939 and ended up in this country also in the 50s. They married and had me. Okay, so after graduating from this fine institution, I've been next year's going to be 35 years that I've been a clinical dentist. I went to work at the San Francisco Department of Public Health, as I was telling Fatima last night, at Silver Avenue Family Health Center, which is the closest clinic to San Francisco General's refugee clinic. And as I pondered, what I was going to say, I was going to say that I realized that I have spent, over the last 30 years, I've probably seen thousands of both immigrant and refugee children that have sat across, the chair from me. And I think that if I never saw a newspaper or read the TV, I would know throughout the decades what country and what part of the world was having the war, the crisis, just by the nationality of children that have sat across from me in my chair. Children from the Philippines, from El Salvador, from Somalia, from Russia, from Bosnia, from the Yucatan Peninsula, from Honduras. And as I was saying, last year I finally had my first Syrian refugee, and I was asking Fatima, why have I not seen more? Because who can afford to be a refugee in San Francisco now? But seeing your presentation just really, even after all the years of clinical experience I've had, has brought back to me that as clinicians, future clinicians or current clinicians, you never know the person that's in front of you, or their parent, the life or the experience that they've had. And like I said, even though I've been a clinician for a long time, it was such a great reminder. And I think our other two presenters are going to, reinforce that to, again, just be aware and be conscious of, like I said, for many of those kids, I was probably the first dentist they ever saw, and how we could frame their whole lifetime experience, and what a privilege, to do the things that we do to help people heal. So thank you so much for attending on behalf of CDA and